Refining antithrombotic therapy for atrial fibrillation and acute coronary syndromes or PCI. What is antithrombotic therapy? Normally, blood flows through our arteries and veins smoothly and efficiently, but if a clot or thrombus blocks the smooth flow of blood, the result, called thrombosis, can be serious and even cause death. We now have an array of drugs that can be used to prevent and treat thrombosis, and there are more on the way, but this was not always the case.
Your heart is a muscle that pumps blood around your body. It's made up of 4 chambers, 2 at the top called the atria, and 2 at the bottom called the ventricles. Your sinus node sends out electrical impulses. Atrial fibrillation, or AF for short, is when other areas of the atria send out electrical impulses too. These irregular impulses cause the atria to twitch. When this happens, blood isn't pumped out effectively, which could cause a blood clot to form. If this clot travels to your brain, it can lead to a stroke. When your heart isn't pumping blood properly, it can lead to symptoms such as tiredness, dizziness, or feeling faint, shortness of breath, or palpitations. How AF affects you will determine the treatment you need. Some people with AF, like Harry, only have mild symptoms, or may not experience any symptoms at all. Harry noticed something might not be right when he felt his pulse was irregular, and sometimes fast. Harry was at higher risk of AF because of his age and high blood pressure. Those with a heart valve problem are also at a high risk. It's important that Harry avoids further strain on his heart by getting treatment for his AF to reduce his risk of stroke or heart failure. The best course of treatment for Harry was anticoagulant medicine, called warfarin, to reduce his risk of having a stroke, followed by a cardioversion, to try and restore his normal heart rhythm. However, some people may need other treatment, such as ablation or other suitable medication. Thanks to his treatment, Harry's AF is manageable and he can return to work and exercise when he feels ready. For more information on living with atrial fibrillation, visit bhf.org.uk/AFib.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary arteries induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrin, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through 2 pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Coronary artery disease is narrowing of the coronary arteries secondary to several risk factors, some of which are cigarette smoking, hypertension, hyperlipidemia, and diabetes. Percutaneous coronary intervention, or PCI, is a procedure used to treat and evaluate partially and completely occluded coronary vessels. Atherosclerosis results from endothelial injury, inflammation, and accumulation of lipoprotein, leading to intimal deposition of particles and narrowing of the coronary artery. The stenotic vessel makes it difficult for red blood cells to pass through. Therefore, the risk of ischemia and infarction is increased. During a percutaneous coronary intervention, an incision is made to isolate the femoral artery. A catheter is inserted into the artery and guided up the aorta to the heart. Live angiography is used to guide the catheter to the obstructed coronary artery. Radiopaque dye is injected into the artery. Imaging determines the location of the stenosis and the diameter of the vessel. Once the vessel is isolated and the obstruction located, a guide wire is threaded through the catheter to the location. The catheter is removed, leaving the guide wire. A balloon catheter is pushed over the guide wire and centered over the blockage. The balloon is inflated to open the narrowed vessel. The balloon is inflated and deflated multiple times to gradually widen the occluded vessel. To ensure that the artery remains unobstructed, a second balloon catheter with a stent is threaded to the location. The balloon is inflated, expanding the stent. For some patients, drug-eluting stents are used to decrease the chances of in-stent stenosis. Drug-eluting stents are coated with a material that will retard new intimal hyperplasia. Blood flow through the coronary artery is restored.
Applications in medicine. Approximately 1 in 5 persons with atrial fibrillation will undergo percutaneous coronary intervention or have an acute coronary syndrome. Anticoagulation in such patients is challenging.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 mg dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 mg dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 mg dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Augustus trial, a 2x2 factorial randomized comparison of apixaban with a vitamin K antagonist and of aspirin with placebo that involved 4,614 patients. The trial evaluated the effects of these interventions on bleeding events in patients with atrial fibrillation who had an acute coronary syndrome or underwent PCI, or both, giving the totality of data a direct anticoagulant should now routinely be recommended for patients with atrial fibrillation who have an acute coronary syndrome or undergo PCI. In the doubled blind comparison of aspirin with placebo, aspirin led to a higher risk of bleeding. Whether the incidence of coronary ischemic events is increased when aspirin is omitted on a background of direct oral anticoagulant and clopidogrel is really the key unknown. The pros: in patients undergoing complex multivessel or high-risk PCI, or in those presenting with high-risk acute coronary syndrome, aspirin should probably not be routinely omitted for at least several weeks or longer, depending on bleeding risk. In patients with a low risk of thrombotic events or a high risk of bleeding, early omission of aspirin therapy and treatment with a direct oral anticoagulant plus clopidogrel is entirely warranted. The cons: the consistency of the trends toward more thrombotic events in the placebo group than in the aspirin group strongly suggests that there may very well have been a significant difference if more patients had been enrolled in the Augustus trial. Because of its lower bleeding profile, clopidogrel was the P2Y12 inhibitor that was used most commonly in the dual pathway regimen, and there is uncertainty regarding its response variability and efficacy, particularly without aspirin. In Ecuador, clinical decision-making should continue to be based on a balanced assessment of three competing risks: cardioembolic stroke, coronary ischemic events, and bleeding. According to the Ecuadorian Cardiology Magazine of Medicine, non-anticoagulation should be promoted with patients with a score of 0. Better control of INR should be promoted. The most anticoagulant used is warfarin, but the use of new oral anticoagulants should be promoted. Conclusions: although guideline committees will now have to grapple with incorporating the results of the Augustus trial into specific recommendations, it is clear that a one-size-fits-all policy is unlikely to apply in these patients.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin obviously before PCI in the hospital, but then at discharge stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after or at the time of discharge that you'd send people home on the dual therapy and allow risk stratification. If you had a high thrombotic risk, a left main stent or something, I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.